Okay, hello. Thank you for watching this video. In this presentation, I am planning to give an overview of evidence-based medicine. And this would be the presentation outline. We'll first look at the importance of evidence-based medicine. I have selected 16 key concepts in evidence-based medicine. We can go through those concepts and I'll provide some examples which may have clinical relevance to psychiatry. And at the end, based on this presentation, there will be a set of 5 self-assessment MCQs. And some information about myself. I'm a consultant psychiatrist based in Chennai in India. I worked for many years in the United Kingdom. And David Sackett, a medical epidemiologist from Canada, is generally considered as the modern pioneer of evidence-based medicine. He has defined evidence-based medicine as follows: that it is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of the individual patient. It means integrating individual clinical expertise with the best available evidence, external clinical evidence from systematic research. And this is the EBM triad, where evidence-based medicine is the place where the 3 different circles meet. So you have the best available evidence, and based on the doctor's judgment or expertise, some of that evidence would be relevant, and but the evidence should also be acceptable to the patient. So critical appraisal is an important concept in evidence-based medicine. So it is a systematic process of assessing the usefulness of a research article by being able to identify its strengths and weaknesses. So all doctors, including psychiatrists, need to possess basic critical appraisal skills. And this lecture aims to give an overview of some of the important concepts in EBM, the knowledge of which should improve a doctor's critical appraisal skills, so that they would be in a better position to assess the quality of research articles. So these are the 16 concepts: case control study, cohort study, randomized control trial or RCTS, systematic review, meta-analysis, sensitivity, specificity, odds ratio, relative risk, p-value, confidence interval, number needed to treat, NNT, number needed to harm, reliability, validity, bias, and confounding. So we can subdivide these 16 concepts. So the first 4 concepts are related to study type: case control study, cohort study, RCT, and systematic review meta-analysis. The next 8 concepts are related to study results. So how the results of the study are presented. So sensitivity, specificity, odds ratio, relative risk. I've grouped them in pairs. I've grouped the related concepts in pairs: p-value, confidence interval, NNT, and NNH. And then finally we have 4 concepts which are related to the study strengths and weaknesses. So reliability and validity, and bias and confounding. So this is the summary so far. So we have we'll be looking at 16 concepts in evidence-based medicine, and we have subdivided them to help us understand better into 3 big divisions. But it's important to realize that evidence-based medicine is a much wider area which covers far more than these 16 concepts. So there are numerous other concepts related to study types, study results, study strengths and weaknesses. But for someone who has not had a formal introduction to evidence-based medicine, the knowledge of these 16 basic points will be a good starting point. So first we'll start with study types: case control, cohort, RCTs and systematic review meta-analysis. And there is a hierarchy of studies whereby studies which are higher in the hierarchy are given greater importance in terms of value added to those studies. So at the bottom you have editorials and expert opinions, which, while very valuable, they might not be generalizable. So the hierarchy refers to how generalizable or how consistent a particular finding is. So then you have case series and case reports. So a case report would be an isolated, unusual case finding. A case series would be a series of such cases. Then you have case control studies, cohort studies, randomized control trials and systematic reviews. So a finding from a randomized control trial would have greater weightage than a finding from a cohort study, which in turn would have greater weightage over a finding from case control studies. And then systematic reviews would have even greater weightage than RCTs. But it is important that each type of study has its own advantages and disadvantages. And sometimes a study type lower in the hierarchy might be more appropriate to study a particular topic than a study that is higher in the hierarchy. But this is a broad division which generally holds good. So we'll first start with case control study. A case control study is a retrospective study. In other words, you go back, you start at a particular point in time, and then you collect information that is already there. So this type of study typically looks at the relationship between a specific exposure and a specific disease or outcome. And there are 2 groups that are compared in a case control study. Cases, these subjects have the disease or outcome that is being studied, and controls, these subjects do not have the disease or outcome. Hence it is called a case control study, because you are comparing cases and controls. And what are you comparing them for? The cases and controls should be matched. That is, they should be similar to each other apart from disease status. And as this is a retrospective study, the information is already available, and the sources of information could be patient notes or interview with the patient or relative. And then what do you compare these 2 groups for? So you calculate the rate of exposure in each group, that is the cases and in the control. So you find out how many of the cases, that is those who have the disease, have the exposure in the past, and how many of those in the control group had the exposure in the past. And this comparison is expressed as an odds ratio. And we will be looking in greater detail on odds ratio a bit later on. The main problem in a case control study is bias. And bias is also a topic that we'll be looking at later in this presentation. And because it's a retrospective study, the study is relatively cheap and less time consuming. And you can use a case control study to study rare diseases because the diseases have already occurred. And let us look at a couple of examples of hypothetical case control studies. So you want to do a study on the potential relationship between smoking and myocardial infarction. So cases would be those subjects who have suffered myocardial infarction, and controls will be subjects who have never suffered myocardial infarction. And then you establish the rate of the exposure, which in this case is smoking, in both cases and controls. And this you can do by checking their medical notes or asking the patient about their smoking history and so on. And if the rate of smoking is different significantly in cases and controls, you express this as an odds ratio. But even if it is significantly different, or if the odds ratio is quite high, it suggests only an association, and you cannot necessarily imply causation between smoking and myocardial infarction, though causation is also possible. Let us look at a psychiatric example. So you want to study the potential relationship between premature birth and schizophrenia. So the cases would be subjects who have schizophrenia, and controls are subjects who do not have schizophrenia. And then you establish the rate of premature birth in both the cases and controls. And the information gathering would be by asking the subjects or their mothers or checking medical notes. If the rates are significantly different, as mentioned before, as expressed odds ratio, it suggests an association between premature birth and schizophrenia. So now let us look at a cohort study. A cohort study is a prospective study. Like a case control study, a cohort study also looks at the relationship between a specific exposure and a specific disease or outcome. And there are two groups compared in a cohort study. The cohorts, these are the subjects who have the exposure, and controls, these are the subjects who do not have the exposure. And the direction of study is prospective, so it is opposite to the direction of study in a case control study. So in a case control study, you go back from disease to exposure, whereas in a cohort study, you go forward from exposure to disease. In a cohort study also, matching is very important. The cohorts and the controls should be as similar to each other as possible, apart from exposure status. The rate of outcome in each group is calculated and compared. This comparison is expressed as relative risk. The main problem in a case control study is loss to follow-up. That is, some of the patients who are initially enrolled in the study do not attend for follow-up appointments. Compared to a case control study, a cohort study is more expensive, and it's also more time consuming because you have to allow sufficient time from exposure for the outcome or disease to occur. A cohort study is particularly useful to study the effects of rare exposures, such as a chemical leak or a radiation leak. Let us look at how we would do the cohort studies using the same examples as we used for the case control studies. So the first example is the relationship between smoking and myocardial infarction. So if you want to do a cohort study, the cohorts would be subjects who are smokers and controls would be subjects who are non-smokers. And you need to follow up both groups for a length of time and then establish the incidence of myocardial infarction in both the cohorts and controls. And if the rates are significantly different as expressed by an abnormally high or abnormally low relative risk, it suggests an association but not necessarily causation. The second example, looking at the relationship between premature birth and schizophrenia. Here the cohorts would be subjects who are born premature and controls are subjects who are not born premature. And then you need to follow up both groups for a length of time, establish the incidence of schizophrenia in both the groups, and then calculate the relative risk. As you can see, for a study to look at this type of relationship, a case control study is better, because otherwise you will have to do this study for a very long period of time, because schizophrenia can occur at any age, though it usually starts by early adulthood. So a condition like schizophrenia, which has a prevalence of about 1% in the population, which would count as a relatively rare occurrence, a case control study would be better and would be more practical. And this is the comparison between case control study and cohort study that we have seen so far. So case control study is retrospective, whereas a cohort study is prospective. The two groups are cases and controls. Here the two groups are cohorts and controls. Odds ratio is calculated, relative risk is calculated, though it is theoretically possible to calculate odds ratio also for a cohort study and relative risk also for a case control study. Case control study is cheaper, less time consuming. Bias is the main problem in a case control study, whereas loss to follow up is the main problem in a cohort study. A case control study is useful for rare diseases. Cohort study is useful for rare exposures. Next we move on to RCT. A double-blind randomized control trial is considered the gold standard in clinical trials that compare different treatments. All subjects in an RCT are patients who have a particular disorder. The patients are then randomly allocated to any one of two or more treatments that are being compared. So typically the comparison is between an active drug and an inactive placebo. Sometimes two active treatments are compared. For example, a new antipsychotic drug that is awaiting approval compared against an old licensed drug like haloperidol. Or the comparison could be between an SSRI and CBT, cognitive behavior therapy. Sometimes more than two groups can be compared. So you can compare SSRI versus CBT versus combination SSRI plus CBT versus placebo versus waiting list group. So randomization, which is an important process in RCT, can be achieved by a variety of techniques. By tossing a coin, so if there are two groups, heads go to group A and tails go to group B, or allocating alternate patients. Computer generated number sequences are commonly used. Blinding is very important in RCTs. So an RCT might be either single blind, where only the patient is blind, that is, the patient does not know which intervention he or she is receiving, or double blind, where the investigator who is doing the outcome assessment is also blind. So he does not know which group a particular patient who is being assessed belongs to. And triple blind and quadruple blind are theoretical concepts. I've never come across these in research studies. And these are the different stages in an RCT. So you have patients who are assessed for eligibility. So say you are doing an RCT of treatments for depression. So the patients need to be assessed using a good diagnostic instrument like DSM-5 or ICD-10, or a rating scale like Beck Depression Inventory or Hamilton Rating Scale for Depression. And the ones that are eligible are then randomized to one or more interventions. And then these patients are given the intervention, they are followed up for a period of time, and then they are analyzed. So you can see that at each stage you might be losing patients. So this highlights the practical difficulty of doing an RCT. And what are the advantages of an RCT? So it's a prospective design. So you have clearly defined treatments, and you have clearly defined patient groups. Bias is minimized, and confounders are equally distributed. So we look at both bias and confounders a bit later on in this presentation. So what are the disadvantages of an RCT? The RCT can be expensive, this time consuming, depending on how long you're going to follow up the patients for. And translating research efficacy into clinical effectiveness may not be straightforward, because an RCT typically uses inclusion and exclusion criteria, say patients not abusing alcohol, not abusing drugs, not having significant comorbid physical illnesses, patient should not be pregnant, and so on. The results that you get from an RCT might not be generalizable to the type of patients that you see in real life. So these are patients who have comorbidities. And there are ethical issues in RCTs. So if an RCT is sponsored by a drug company, the release of information from the research may be selective. And sometimes an RCT may need to be terminated prematurely. Say if you are comparing a new drug with an existing drug, and if the benefits of a new drug are clearly obvious, say and even before the study is completed, so you might have to terminate the RCT. So for example, if it's a new drug for dementia, and the new drug is really good in reversing the symptoms of dementia, which is not available with any of the existing drugs, then it might be unethical to deny the drug to other patients. Similarly, if the new drug has very significant hazards which are irreversible, say the new drug has major cardiac side effects, or say it causes blindness, then you might have to terminate the study even before the originally stipulated time. The next group of studies are the systematic reviews and meta-analysis. A systematic review is a summary of research studies. So it's a summary of RCTs. It is done to answer an important question. Say for example, if you want to answer a question like, are atypical antipsychotics better than mood stabilizers for acute mania? Then you look at all the double-blind RCTs that have been done on this topic, and then you summarize them. And a systematic review uses a systematic method to identify these studies. Then each selected study is analyzed and a qualitative summary is given. On the other hand, meta-analysis is a statistical summary of a systematic review. So it gives a quantitative summary. But these days, systematic reviews are almost always accompanied by a meta-analysis. It is unusual to find a standalone systematic review. And some of the methods that are used to identify relevant studies, so medical electronic databases like PubMed, Embase, and contacting leading researchers in the field who might be aware of other studies, PhD dissertations, contacting drug companies for unpublished research. And now we look at some of the concepts relating to study results. So we look at 8 concepts. So we'll start with sensitivity and specificity. So these concepts are used to assess the usefulness of a new diagnostic or screening test. They refer to how well a new test performs in comparison to an existing so-called gold standard test. For example, let us assume that a new depression scale is being developed. The gold standard can be DSM-5 or ICD-10 or an existing depression rating scale. So what is sensitivity? Sensitivity is the proportion of subjects who have the disorder as diagnosed by the gold standard, who are also picked up by the new test as having the disorder. In other words, it is the ability of the test to identify those who really have the disorder. On the other hand, specificity is the proportion of subjects who do not have the disorder as per the gold standard and who are also excluded by the new test as not having the disorder. In other words, it is the ability of the test to identify those who really do not have the disorder. So to calculate sensitivity and specificity, you need to administer both the gold standard and the new test on a sample of patients. So you will get 4 groups. The first group would be true positive, so those who test positive on both the tests. The second group would be false positive, those who test positive on the new test but negative on the gold standard. And the third group is false negative, those who test positive on the gold standard but negative on the new test. And the fourth group is true negative, those who test negative on both the tests. So you can show these 4 groups on a 2 by 2 table. So where A is true positive, B is false positive, C is false negative, and D is true negative. So using the definitions that we discussed earlier, the sensitivity from the 2 by 2 table would be A divided by A plus C, where A refers to those who are positive on the new test, and A plus C are those who are positive on the gold standard test. And specificity would be D by B plus D, where D is new test negative and B plus D are all those who are gold standard test negative. So let us look at a practical example. Let us assume that a new test for depression is developed called DIP-N, and let the gold standard for comparison be the ICD-10 criteria for depression. So you administer both the tests to all the study subjects, and you will get 4 compartments in the 2x2 table. True positive would be positive on both the tests. False positive would be ICD-10 negative but DIP-N positive. False negative would be ICD-10 positive but DIP-N negative. And true negative would be negative on both the tests. So in general, sensitivity and specificity should both be at least 80%. Odds ratio and relative risk. These are similar but not identical concepts. Typically, odds ratio is used for case control studies and relative risk for cohort studies. Both are ratios. Odds ratio is a ratio of odds, while relative risk is a ratio of probabilities. An odds ratio of 1 means there is no difference between cases and controls. A relative risk of 1 in a cohort study means that there is no difference between cohorts and controls. A similar 2x2 table as the one that we used for sensitivity and specificity is useful to calculate odds ratio and relative risk. So, but here the true positive would be exposure and outcome positive, because in a cohort or case control study, we are looking at the relationship between exposure and outcome. So true positive includes those subjects who have both the exposure and the outcome. False positive, they have the exposure but not the outcome or disease. False negative, exposure is negative but the disease or outcome is positive. And true negative, both the exposure and outcome are negative. So let us look at odds and probabilities, because as I said, odds ratio is a ratio of odds and relative risk is a ratio of probabilities. So this is the relationship between odds and probability. So the odds equal to probability divided by 1 minus probability. So let us look at an example, tossing a coin. The probability of a head coming up is 1 by 2, because you have 2 possibilities, heads or tails, and so probability of a head coming up is 1 divided by 2. The odds of a head coming up is 1 divided by 2 divided by 1 minus 1 by 2, which will give you 1. So let us look at another example of throwing a dice. So the probability of number 4 coming up is 1 by 6, because there are 6 possibilities, 1, 2, 3, 4, 5, 6. And the odds of 4 coming up would be, if you use the formula of probability by 1 minus probability, you will get 1 by 5. So you will always find that the odds are greater than probabilities. So how do we calculate the odds ratio? So by definition, odds ratio is the ratio of the odds of exposure in cases to the odds of exposure in controls. So from a 2 by 2 table, the odds of exposure in the cases would be A by C, and the odds of exposure in the controls would be B by D. So the odds ratio would eventually come to AD divided by BC. So if you know how to plot the 2 by 2 table, you can easily calculate the odds ratio. And what is relative risk? So the relative risk, as we saw earlier, is a ratio of probabilities. So it is the ratio of the risk or probability of outcome in the cohorts to the risk of the outcome in the controls. So from the 2 by 2 table, the risk of outcomes in the cohorts would be A by A plus B, and the risk of outcome in the controls would be C by C plus D. So the relative risk, if you calculate, would eventually come to A into C plus D divided by C into A plus B. Now, I will suggest that you refer back to that 2 by 2 table again, and it would make it clearer. Now let us move on to p-value. P stands for probability. So it is the probability that the result observed in the study is purely due to chance. So in medical research, a p-value of less than 0.05 is considered to be statistically significant. So what does a p-value of less than 0.05 mean? So it means that there is less than a 5% chance or likelihood that the result is due to chance. In other words, that the result is not a real result, but it's purely due to chance. So now let us look at some significant and non-significant odds ratios and relative risks. So these two are significant, an odds ratio of 1.8 and a relative risk of 0.4. They are significant because number one, they are not 1. So if they are 1, it is not significant. And number two is the p-value is less than 0.05. And these two results are not significant because the odds ratio is 1. So even though the p-value is less than 0.05, because the odds ratio is 1, it is a non-significant result. And the second is the relative risk is 2.6, which on the face of it seems significant, but because the p-value is greater than 0.05, this makes this relative risk non-significant. The next concept is confidence interval. So when we are doing a research, we are only typically conducting the result on a sample, and then we extrapolate that result to a bigger population. So we cannot be certain that the value that we get from the research is the true value in the population. There is always going to be a margin of error. So we use the concept of confidence interval. So the confidence interval is a range of values within which the true value in the population is likely to lie. So the larger the sample size, the narrower the confidence interval. So the confidence interval is usually expressed as a percentage, and in medical research we generally use 95% confidence interval. So the higher the percentage, the higher the degree of certainty, but then the confidence interval will also become wider. So for ratios such as odds ratio, if the confidence interval includes 1, then it is not a significant result. And for absolute differences, for example, differences in scores on a rating scale, if the confidence interval includes 0, it is not a significant result. So let us look at some examples. So the following odds ratio and relative risk are significant. So the odds ratio of 1.8, because it is not 1, the 95% confidence interval of 1.2 to 2.2. So that range does not include 1. The relative risk of 0.4 is significant because the confidence interval, the whole range falls less than 1. And the following odds ratio and relative risk are not significant. Odds ratio of 1 because it is 1, so we need not even look at the confidence interval. And a relative risk of 2.6. This is, on the face of it, looks significant, but the confidence interval ranges from 0.9 to 5.3. So because it includes 1, this becomes a non-significant result, even though the relative risk is 2. Now let us move on to number needed to treat. So this refers to the number of patients who need to receive the experimental treatment in order to result in one additional positive event compared to the control treatment. So the formula is number needed to treat is equal to 1 divided by absolute benefit increase. So number needed to treat is a measure of treatment efficacy or effectiveness. The lower the number needed to treat, the more effective a treatment is. So what is number needed to harm? It is the number of patients who need to receive the experimental treatment in order to result in one additional negative outcome in comparison with the control treatment. So number needed to harm is equal to 1 divided by absolute risk increase. So number needed to harm is a measure of treatment safety. And the higher the number needed to harm, the safer a treatment is. Let us look at an example. A new drug for depression called drug X is compared with placebo in a randomized controlled trial on depressed patients. 70% of patients on drug X and 20% on placebo achieve remission at 3 months. What is the NNT for remission? So the formula is 1 divided by absolute benefit increase. The absolute benefit increase is 70% minus 20%, which is 50%, or 0.5. And number needed to treat is 1 divided by 0.5, which gives you 2. So 2 patients need to be treated with drug X to result in 1 additional remission compared to placebo. Let us look at an example for number needed to harm. This is the same study. So you find that 20% of patients on drug X and 10% on placebo develop significant weight gain by 3 months. So what is the number needed to harm for weight gain? So using the formula for number needed to harm, you get 1 divided by absolute risk increase, and the absolute risk increase is 20% minus 10%, which is 10% or 0.1. And the number needed to harm would be 1 divided by 0.1, which is 10. So 10 patients need to be treated with drug X to result in 1 additional case of weight gain compared to placebo. So now we move on to reliability and validity. So reliability refers to the consistency or repeatability of a test, and validity refers to the ability of a test to measure what the test is supposed to measure. So as a concept, validity is superior to reliability because a reliable measure need not always be valid, while a valid measure should always be reliable. So a test should pass the test of reliability before it can pass the test of validity. Now, I'll just mention a few types of reliability: inter-rater reliability, test-retest, split half, and alternate form reliability. as this is just an introductory lecture, I'm not going to go into the details of these different types. And similarly, there are different types of validity: face validity, content, criterion, and construct validity. We now move on to bias. Bias, by definition, is a systematic error. If a certain bias has entered the study, it cannot be controlled for in statistical analysis. So you need to, before you start the study, you need to make sure that there is no significant bias. So bias is particularly a major problem in case control studies, but it can occur in other study designs as well. What are the types of bias? Selection bias, the way in which you select the subjects for the study. Recall bias, particularly in a case control study where the patient might have to recall something in the past. Observer bias, where because of a bias in the researcher, they might do the study in a particular way or record certain things in a particular way. Response bias, so people who respond either to participate in the study or who attend follow-up, they might be different from those who do not respond or do not attend follow-up. So that would be a bias. Publication bias, so a study which shows positive results might be more likely to be published than a study which shows no difference. And confounding. A confounder is a factor that is independently associated with both the exposure and the outcome. So if the confounder is not controlled for, it will lead to a spurious association between the exposure and the outcome. What it means is that in reality there is no association between the exposure and the outcome, and it is because of the confounder that there is this association. But if you do not control for the confounder, then you will find the spurious association between the exposure and the outcome. So by randomization, even if there is a confounder, it helps to equally distribute the confounders so that it does not lead to a false association. And statistical techniques like stratification can control for confounders. So in this way it is different from bias. Whereas bias cannot be controlled for after you start the study, confounding can be controlled for by using statistical techniques like stratification. So what are the common confounders? Age, gender, socioeconomic status, alcohol or drug use, education level. So you need to make sure that you note the rates of these confounders in the different groups that are being compared, so that any difference that you find between those groups is a real difference and not because of confounders like these. Let us look at an example of confounding. Say you do a study looking at the relationship between alcohol and lung cancer. If you do not control for smoking, you might actually find that there is a relationship between alcohol and lung cancer. But if you identify smoking as a potential confounder and then you look at the rates of smoking in those who use alcohol and those who do not use alcohol, what you might find is that the rate of smoking is higher in those who use alcohol, and actually that is responsible for the higher incidence of lung cancer among those who drink. So by identifying and controlling for the confounder, you will realize that there is actually no relationship between alcohol and lung cancer, and that any relationship that you originally found was due to smoking. So now we have covered all the 16 concepts. That was the purpose of this lecture. And before we finish, let us do 5 multiple choice questions. So the first question is, which of the following is not true regarding case control studies? These studies are retrospective. Patients are randomized to one of the two groups, cases or controls. Odds ratio is calculated. Bias is the major potential problem. So if you want, you can pause and select an answer. So the correct answer is patients are randomized to one of the two groups. So that option is not true. So the other 3 are true. Whereas randomization is not something that we do in case control studies. That is something we do in randomized controlled trials. So in a case control study, you have cases who have the disease and controls who do not have the disease. Question number 2. A cohort study is conducted to look at the relationship between cannabis use at age 18 and schizophrenia by age 30. Which of the following is correct? Number 1, cohorts are patients with schizophrenia. Number 2, controls are patients without schizophrenia. Number 3, cohorts are cannabis users at age 30. Number 4, controls are cannabis non-users at age 18. So if you want, you can pause now. And the correct answer is number 4, controls are cannabis non-users at age 18. So number 1 is wrong because the cohorts are cannabis users at age 18. Number 2 is wrong because controls are non-cannabis users at age 18. Number 3 is wrong because cohorts are cannabis users at age 18. And so because 1 to 3 are wrong, number 4 is the correct option. Question 3. Which of the following is usually not an advantage of double-blind RCTs? So if you want, you can pause now. And the correct answer is number 3. So an RCT is not cheap as it is a retrospective study. In fact, it is expensive as it is a prospective study. The other 3 options are true. Number 4, question number 4. Which of the following is a statistically significant test result? So if you want, you can pause. And the correct answer is option 3. Option 1 is not statistically significant because the p-value is only less than 0.5. So we need a p-value of less than 0.05. And option 2 is also not statistically significant because the confidence interval is 0.9 to 5.7 and it includes 1. And so odds ratio, or the option 3, is statistically significant because the odds ratio is 2.8, which is different from 1. The 95% confidence interval does not include 1, and the p-value is less than 0.05. The final question, treatment A and treatment B are compared against placebo. So compared to placebo, treatment A has a number needed to treat of 5 and number needed to harm of 10. And treatment B has an NNT of 10 and NNH of 5. Which of the following statements is true? So if you want, you can pause now. And the correct answer is option 3. Treatment A is more efficacious and safer than treatment B. And why is that so? Because the number needed to treat is 5 for A and 10 for B. So as we saw earlier, the lower the NNT, the more efficacious the treatment. And why is treatment A safer than treatment B? The number needed to harm is 10 for A and 5 for B. And we saw earlier that the lower or the greater the number needed to harm, the safer a treatment is. So because treatment A has an NNT lower than treatment B and an NNH higher than treatment B, it is more efficacious and safer. And that brings us to the end of this lecture. Thank you for listening. Hope you found this lecture useful. Thank you.